My name is Steve Worrall from Positive East, and I'd like to welcome my three colleagues who will be presenting their papers today. It's the after lunch slot, so please no snoring from the back if you do fall asleep, and if your colleague can actually just nudge you to keep you awake. What we'll be doing is all three papers will be presented, and there will be questions after that particular session. So the first person I'd like to introduce is Dr. Alison Brown from AXA. Alison is a consultant scientist in HIV and AIDS reporting section. She has a research interest in measuring levels of transmissible virus and monitoring programs to ending transmission of HIV. So what I'd like you to do is please give a big hand to everybody. In the question and answer sessions, please be kind. It's quite scary being up here for some people. And over to you, Alison.
Thanks very much. So as Steve says, my name is Alison Brown and I'm from the UK Health Security Agency, and I'm going to present today on how we measure people who are not retained in HIV care, how many people are not in care, and who are those people. So as all presentations, we'll start off with last time's action plan. So one of the key elements of the action plan published in 2020 was to improve retention and engagement in HIV care. And that it really is critical because of several reasons. So this graph here shows a number of people living with transmissible levels of virus. Some of these people are in care, but this is important because people who have transmissible levels of virus may be more likely to become ill, more likely to have higher levels of morbidity, but also can pass on HIV to sexual partners. Now, not all of these people are not retained in care. If you look at the top bar, you'll see the first portion of the bar graph are people who we estimate to be undiagnosed. The second portion, the darker blue and the lighter blue together, are people who are not linked to care after diagnosis, and those who are not retained in care. And that adds up to about 6,700 individuals. So what's important here is that we now have more people who have a diagnosed HIV infection but who are not retained in care than we do people who are living with undiagnosed infection. That means we need to invest as much energy into getting people back into care and sustained and supported to be in care as we do with HIV testing. And that's important not only to reduce morbidity and deaths, but also to reduce undiagnosed infection. Just for completeness, the other elements of people who are have got transmissible levels of virus are people who are in care but not yet started treatment, and people who are treated but not yet supported to attain viral loads. So clearly, there's lots of work to be done across the spectrum. This year, we will, in our monitoring and evaluation framework, which will be published on the 1st of December, update these figures, and we'll also make sure that we integrate people who are not retained in care as part of the 95, 95, 95 metrics, and we'll show the impact of that. So this is how we measure non-retention in care. We have two different definitions. We send lists to clinics across the country of people who are not retained in care. That is, people who have not been seen for care for 12 calendar months. And we use that for practical purposes so that clinics can prioritise follow-up on people not seen for care who are not known to be seen in other clinics. At UK Health Security Agency, we were able to have able to link people across clinics so we can tell if somebody has moved across the country and you don't need to invest time in trying to follow up that individual. But we're really focusing on people who have not known to be seen for care anywhere in the UK. For our surveillance definition, we use a period of 15 months, and that's because national guidelines suggest if you have HIV and you're well, you should be seen at least once per year. But because there is a bit of slippage, for instance, you may have last been seen in December 2019, and then again in January 2021, that is still roughly a year. So we're using the 15-month to make sure that we're not erroneously including people who are seen on average once a year. So here are the figures of people who are not retained in HIV care. These are people who have been diagnosed but not seen for at least 15 months. On the left-hand side of the graph, you can see that the numbers who are not retained in care increased during COVID and have not yet gone back to pre-COVID levels. Just as we're seeing in the headlines all the time about education, with people not being in schools, we're still seeing much higher levels of people not in HIV care than we did before COVID. And on the little yellow dots show the proportion of people who are not retained in care on the second y-axis. The right-hand side of the graph shows people who have not been in care for at least 5 years, but we're less certain of these data for two reasons. Firstly, these may be due to difficulties matching between patients. And secondly, we don't have information on people who have left the country other than our follow-up with the sites. So we're less confident on those. So we think by focusing on people not seen year on year, as a cohort going forwards, we'll be able to track progress and interventions to get people back into care. So roughly we have about 6,500 people who are not in care each year, and we have about 99,000 people living with a diagnosed HIV infection. This graph here shows it by the different exposure groups. It starts off with gay and bisexual men on the left, heterosexual men in the middle, and heterosexual women on the right-hand side. And what you can see is that the actual numbers not retained in care reflect the makeup of people living with a diagnosed HIV infection. So for the gay men, for instance, you'll see that most people who are not retained in care are white, but you'll see slightly higher proportions of people who are not retained in care of other ethnic groups. And that's purely because of people living with diagnosed HIV infection who are gay men. Most people are white. For men reported to have sex with, for heterosexual men and heterosexual women, you'll see disproportionately Black African populations are the biggest group who are not retained in care each year. But you'll see a high proportion in white other groups and white and other mixed groups. And we're going to do some further work digging down into looking at levels of deprivation, etc., to look at this in more detail. We're also able to look by country of birth and first place of diagnosis. So on the right-hand side, you can see here that there's a higher number of people, about 5,000 people not retained in care who were born abroad, and a lower number of people who are born in the UK. Again, we aren't able to look at people who have left the country, so it might be that there are some biases there. The one thing that we do know for certain is that we do see higher rates of people not retained in care amongst younger people. And of people who are in care and on treatment, we know that levels of viral suppression are also much lower amongst younger people, people aged 15 to 25. So we see this with other chronic conditions as well, such as diabetes. We're hoping to unpick, dig down to the data to see whether these are people who have been born HIV positive and are possibly transitioning to adult care and need further support as they move from paediatric services, or whether look at some of the broader reasons behind it for this group. Obviously, it's a smaller group, but as a proportion, these groups are at higher risk of not being retained in care. So what do we do with these data? So twice a year, we send lists of people who have not been seen for care at any site for 12 months to each clinic. And that allows, and we take away people who have been seen in another clinic or those that have died. And this means that clinicians and healthcare workers can focus attention on trying to engage the people back into care. But clearly this is very time intensive, and also interventions to encourage people back into care need to be sustained. A temporary fix might mean you're back in care for 1 year, but some of the preliminary work does show that we need to keep on sustaining interventions such as trying to address some of the structural determinants such as being at work, not being able to afford it, childcare, etc., and other issues that we know are barriers to being in care. And our next steps are going to be looking at predictors of people who are not retained in care each year as well. I'm not going to go through this flow diagram because I always get confused, but I'm just going to talk through some of the key messages here. So of the around 7,000 people, 6,000 people who are not retained in care each year, we know that by about a year later, 50% come back. So these are not necessarily people who are permanently not in care. That could be due to the efforts of people trying to get people back into care. We also know that of the 50% of people who come back, a significant proportion of them are virally suppressed when they return to care. And that suggests to us there are not people who are actually not retained in care. Either there's not been recorded because they've been seen in online services and information hasn't flowed through to UK HSA on virtual attendances, for instance. So if we adjust for those people who are virally suppressed at apparent reattendance, the 7% of people not retained in care actually reduces to 5%. So we think about 5% of people are not retained in care. So that's the takeaway message. We are making that adjustment based on viral suppression when people do get seen back into care. And then looking at it from the flip side, of people who are then re-engaged in care a year later, we know that 63% of those, it is an effective re-engagement. And what that means is within 6 months of re-engagement, those individuals are virally suppressed again. And that's the definitions we're using. So we're using definitions for being not retained in care year on year. We're adjusting it to account for people who are virally suppressed at the time of re-engagement. And then we're looking at a measure of effective re-engagement, which is of people who are not retained in care, what proportion then went on to be virally suppressed within 6 months. So in conclusion, we have been exploring different ways to monitor non-retention in care because it's a public health priority. We now know there's more people not retained in care than there are people who are undiagnosed. And it's critical to reduce mortality and also to reduce onward transmission. The overall numbers have increased since COVID and have not returned to pre-COVID levels, which is particularly of concern. We know that younger people in particular and also white other groups and other mixed ethnicities are people who are apparently most at risk of not being retained in care. We also see a slightly higher burden amongst women than compared to other groups. We are continuing to support clinics and sending lists to each trust to focus retention in care. And we're developing these measures as part of our local care pathways, working with local authorities so that people can monitor retention in care at a local level and devise initiatives. But we have the tools now to be able to monitor the impact of interventions to get people back into care and meaningfully, effectively re-engaged. And then one final plea is, we can only measure this if we have accurate data. If we do have data missing, it will affect the numbers of our estimates of people who are not retained in care. So if you do work at the clinic, it really is beneficial to work with you. And thank you very much for your support and to getting high quality data given to us promptly. And finally, I'd like to thank everybody in the HIV team, particularly Veronique Martin, who produced most of these slides and her analysis, and also all the people who provide us with data. Thank you very much.
Great, thank you, Alison. And I think a lot of information to think about and think about how we can apply it in the work we do. The next person who's going to speak is Dee Wang, and I've got some crib notes here about Dee, so please bear with me. Dee is the Deputy CEO of Spectra, where she leads the organisation's monitoring and evaluation efforts. She has over 20 years' experience in HIV prevention and has worked extensively with MSM, sex workers, and people living with HIV. Dee has, I know from experience, has a very strong background in data management, capacity building and communication, and has the advantage of also working with the Chinese National Centre for HIV Control on the Global AIDS Fund. So I look forward to this presentation, and Dee, thank you.
Thank you. What a wonderful introduction. I just made me feel better about myself. Thank you, everyone. Thanks for being here listening to me. And today we are going to delve into a crucial piece of work that the GMI partnership has done. So Spectra, Steve introduced me as a Spectra person, but actually Spectra is part of the GMI partnership. So this work is actually delivered and commissioned by GMI partnership. So this work is focusing on the factors that influencing the disengagement and re-engagement in HIV healthcare. particularly within London's diverse communities. So this is a literature review, intend to provide insight to barriers and facilitators to continue care, especially in the context of HIV prevention and support services. So in case you don't know who GMI Partnerships is, bear with me if you know that already. So GMI Partnership is a London-based collaboration between 3 organizations, Positive East, Metro Charity, and Spectra. So we focus on sexual health and HIV prevention. We provide targeted outreach, education, and HIV testing and support services, so aiming to reduce HIV prevention and improve overall sexual health well-being. So I don't think I need to explain to you more about the importance about disengagement, why we need to tackle it. We all understand the impact of non-engagement as higher mortality and then mobility, increased HIV transmission, and overall public health implications. So considering all these factors, or these impacts, GMI decided to do a piece of work and to look at factors which affect this disengagement from and re-engagement into HIV care. And so we hope that all this finding will subsequently used to shape treatment and healthcare. In late 2023, the partnership carry out these extensive reviews and to try to better understand the situation. And so the database searched, including PubMed, organizational websites, and government and the third sector's reports. So use the keywords like mentioning here, I'm not going to read them out. And this research yielded 27 studies, and that were all included in this review. And first, we want to focus on disengagement. So what are the factors leading to disengagement from care, and which group are more likely to disengage from care? So disengagement from HIV care is shaped by very complex and interplayed of factors. It's deeply entwined with people's identity and the social conditions, such as race, gender, sexuality, age, and then health status. So which we summarize them, categorize them into individual factors. So these individual factors significantly influence the individual's engagement with care. For example, like Alison actually mentioned earlier, we found that women in heterosexual community are more likely to disengage from care, and both sides of the age spectrum, both older and younger, are actually likely in higher risk of disengage from care. And so unfortunately, we don't have much data regarding the trans communities here, so that will be a gap that we will try to address in the future. And I need to highlight here, when we look at all these individual factors, we need to realize there's an intersectional identity characteristics. So one person doesn't just about their age, we're not just talking about their gender, they all connected with each other. So for example, like racially minoritized group, they face compound challenges. They experience not just health disparities and limited access to quality health care, but also there's additional layer of like stigma and discrimination, and this barrier often intersects with like social cultural factors such as cultural beliefs and practice, which can further hinder access to care. And moreover, we look at social determinants of health. So these are conditions in which people live, work, and growth, as defined by the World Health Organizations. So this further complicates the engagement in care. Issues like poverty, migration, domestic violence, housing instabilities, and the lack of education or community support can significantly impact the care continuity. So lastly, we look at treatment and care factors. So they add another layer of complexity. So those dealing with complicated treatment regimens or multiple medications might find it very challenging to stay stay engaged, especially if they've been diagnosed for a long time and then they are not achieving viral depression successfully, they're probably more likely to actually drop out from HIV care. So after engagement, we look at what is actually the key factors to helping people to re-engage back into care. So re-engaging people living with HIV care requires a multifaceted approach to address both social and health factors that we mentioned, healthcare factors that we mentioned earlier. So firstly, we look at social and community factors. So peer support, as mentioned by many studies we revealed, has proven to be highly effective in re-engaging people in HIV care. So by meeting people's need in a more holistic way, peer-led initiative provides a sense of community and a shared experience that can motivate individuals to return to care, and additionally, community-based testing options kind of provide testing options in a sort of a friendly and then a more supportive environments that help reduce barriers to re-engagement. And next, obviously, we've been highlighting this a lot in the whole conversation today, is we have treatment care and diagnosis factors in the health system. So the strategies such as like self-testing and brow testing in A&E departments, they're all making things easier for people. So they make people easier to re-enter the health pathway. And this method also reduce stigma and increase accessibility and make sort of a testing a more routine part of healthcare, which can encourage those who have disengaged from HIV care back into the service that they need. And there are also, we noticed that there are patient monitoring tools available now, like Alison was introducing to us, like clinical stewing, auditing, and recalling patients back to the clinics. That also helped to identify those who might be falling out of this care system and then reach out proactively. So after all these factors, we also look into interventions, what intervention might actually help to, I missed this key point. Yeah, how can I miss this one? So this is one of the last one, but actually the most important one probably is stigma. So stigma, whether it is sort of impersonalized, is perceived, or is enacted, it creates a huge barrier to people, for people living with HIV. So it can lead to fear of judgment, discriminations, and lead to social exclusion and discouraging individuals from seeking and continuing care. So stigma often intersects with other aspects of the person's identities, such as race, gender, and sexual orientation, so amplifying its impact. And after looking at these factors, we turn to interventions. So we want to find out what kind of interventions been told that works to retain people. So we have put all this, what we found, into a table here, and outlining various intervention strategies that addressing the factors we mentioned earlier. So it covers sort of reducing stigma through healthcare professional training, mental health support, combating poverty, addressing substance use, and culturally tailored intervention. The aim is to actually target specific groups, and including those experiencing like mental health issues, poverty, or racial minorities, or to improve overall care and support. And these interventions, that they are focusing to addressing those interconnected factors, which are essential for developing more comprehensive and equitable strategies to support those in need. Also, back to stigma again, and addressing stigma through education, awareness, and inclusive healthcare practice is essential to improving engagement in HIV care and ensure everyone feels safe and supported in accessing the service. Okay, so moving on, what actually lead people back into the service? So what helped in re-engaging? So this actually includes expanding testing options, like we pretty much covered earlier, and reducing stigma through targeted interventions and providing a peer support. So we focus on a collaborative approach, with healthcare teams and then utilizing tools like the patient's reported outcome measures, prompts, and to improve patients' outcome and their support services. So by leveraging community support and improving access through strategic healthcare practice, we can create a more inclusive and supportive environments that encourage re-engagement back to care. So I'd also like to highlight some of the critical gaps that we've found, and then we want a future direction to engage that emerge from our review. So there is a pressing need for longitudinal studies. So what we found nowadays is quite variable, but they are snapshots of what's happened at the moment. So a deep understanding requires tracking the individual over a long term, and then longitudinal research actually will help us to better understand the dynamics of disengagement and re-engagement, and identify patterns and assess a long-term effectiveness of the interventions. And secondly, we want to understand better about some very underrepresented populations, such as trans identities, people with trans identities, and those from diverse ethnic backgrounds, and individuals with like co-current conditions, and all those who living in a very limited, resource-limited setting. And addressing this in each gaps will actually ensure the intervention are inclusive and effective across all segments. So lastly, again, multidisciplinary approach is crucial, and it is inherently complex and multifaceted. So there's lack of sort of a study looking into a combine of medical, psychological, social, or economic, sort of all multidisciplinary research into data that we actually would like to see. So these are the gaps and then the future directions that will be helpful. To conclude, so first I'm giving you the list that we found out. These are the groups are more likely to disengage from care, from the finding from the reviews we found. And so we do want people to realize that although we're giving you a list of people who are more likely to disengage, but we want to highlight the significant shifts from the traditional binary view of a patient being engaged or disengaged from HIV care. Instead, it's actually in sort of a nuanced perspective. Like, we need to recognize patients' engagement exists on a continuum. So this continuum knowledge, engaged care, means that this is not a static status. People can actually get in and out of the care. It's a very dynamic process that can vary over time. So understanding this continuum is crucial when we design and then implement our services or interventions. So we need to move beyond a one-size-fits-all sort of solutions instead of tailor our approach to address the diverse and evolving needs of our people who live with HIV. So our review also identifies several barriers to engaging in HIV care and support. They are complex and then multifaceted, so ranging from structural challenges, such as accessing healthcare facilities, to personal factors, including stigma and mental health issues. And addressing these barriers requires a very comprehensive understanding of the factors that's actually contributing to disengagement. And moreover, the intervention aimed at retaining individuals in HIV care must be tailored to meet the need of a diverse and intersectional populations. This means taking into account of various social, economic, and cultural factors that influence the individual's ability to stay engaged in care. So again, a multidisciplinary approach is essential for effective intervention and collaborations across different sectors, including healthcare providers, social services, and community organizations, will ensure the strategy are holistic and address the broader spectrum of factors. So thank you. And if you're interested with the full report, that QR code you can scan, and once you get hold of this PPT, you can click on the link straight away. And thanks for all the authors of this piece of research. And if you have any questions, feel free to contact us here. Thank you.
Thanks, Steve, for that. I think in the conclusions, there's probably quite a few questions that could potentially be asked. And also a big thank you for Dee. I don't know about you, but sometimes the papers that are produced are a bit overwhelming with just pure statistics and everything else. And it's nice to see something distilled in a different way. The third speaker is Garry Brough from Fast Track Cities London. Some of you might know Garry in a different guise, having worked in the voluntary sector for the last 25 years. Garry has actually been living with HIV for 33 years, and the main focus of his work is about increasing peer support in different locations. So the presentation is about looking at the key elements of the 2020-2023, he says, falling over his words, Fast Track Cities Improvement Collaborative. So thank you, Garry.
Thanks, Steve, and thank you for your work in delivering the programme at Positive East on this. So I'm speaking on behalf of Fast Track Cities London as the programme manager for the current round of programmes. But for this presentation, I was also the lead at Positive UK for the work that we did at Chelsea and Westminster. So I'm wearing two hats, which is not unusual for me. We've heard the information around what the data is and what the approaches could be, and this programme really looked to think about what the solutions could be on a practical level. So in 2020, Fast Track Cities London funded a range of improvement collaborative projects to work across HIV from prevention testing onto post-diagnosis support, and it really brought together a range of community organisations to work in partnership and to pilot and try out quality improvement methodology to look at better practice and better results. And so the focus of this presentation is three specific projects which are delivered by Positive East, Positive UK and Metro with their local clinics, HIV clinics, to integrate peer support within the clinical pathway and to think about the different approaches that were needed around engagement in care. So what was done with each of the projects was slightly different aims, with the idea that you didn't want to have everyone just looking at the same thing. We want to be able to compare and contrast. So in North East London, through Positive East, there was the implementation of wellbeing assessments and inclusion within the MDT to look at whether there were a better identification of unmet needs and, you know, those wider determinants of health that result in people dropping out of care. And then what that could do to then make the referral into the additional support that would then hopefully deal with those issues and support people to stay engaged in care. In South East London, Metro provided a re-engagement in care option. And so they had a peer support worker that worked with individuals around individually tailored support programs to deal with the challenges that they were experiencing that had resulted in them dropping out of care, and then support them to achieve an undetectable viral load, but also to deal with those determinants of health by referral back into the voluntary sector support. And then the third one was for North West London with Child West Clinics, was Positive UK, where we were implementing peer support workers in the clinic and looking at what the pathways were to accessing support, to try and shorten the journey that people had to go to access peer support, to be able to have peer support workers in the MDT, and then to make those referrals into the ongoing support that was needed when issues were identified. And so really all of them relate to wider determinants of health. But what I would flag up here is that that's not just benefits, immigration, housing, nutrition. Primarily, and this is what we've seen from some of the research that's been done in South East London, one of the main issues for people dropping out of care is stigma. It's already been addressed here. And if you don't deal with the stigma first, then all of those other things become just an increasing and compounded impact. So at the point of diagnosis, at points of crisis, or at re-engagement in care, that peer-delivered perspective is what challenges stigma most effectively, we believe. And you know, I'm hoping that the evidence that we have by the end of this next round will demonstrate it conclusively. But it has been shown to be effective in the programs that I'll show you now. So in relation to the results of what was delivered, Positive East, and they work with BARTs and barking, supported, oh, I'm going to need my glasses. Yeah, oh no. Oh, there you go, that's better. The angle is terrible for that one. So they supported over 480 people. And what they saw as a result of that collaboration within the clinic, compared to what the normal referral pathway was, it was a 68% increase into the voluntary sector. So that's 68% of people that actually those needs would not have been identified if the peer support worker hadn't been there and if they weren't undertaking those assessments. The other thing to say with this is that lots of people are talking about PROMs and this very, very slow implementation of PROMs, patient-rated outcome measures. What's been done with this and with the tool that we're currently developing is looking at PROMs and saying, PROMs are great. They're great for a snapshot every year as to where people are at, but what we're trying to consider is crisis management here, and therefore we need to have a more detailed and a more structured assessment that looks at unmet needs, and so that's what was done with this project. The Gilead Wellbeing Thermometer was adapted to consider more wide psychosocial issues than just the medical nature of things. So when you look at then what happened as a result of those referrals, there was 60% of those that were referred in received additional emotional support, and there was a partnership with Living Well for their Connect Well services for anyone living in London. That was part of the programme. Housing outcomes improved for 35%, and for anybody that's had to try and deal with housing, you'll know that although that's only a third of people, that's nothing short of miraculous, because it's a really, really tough one. And financial outcomes improved for 69%. And so when you think of nearly 70% of the people that were supported having a greater financial stability, the potential then to maintain that engagement and care is massively increased. In fact, I'll throw in another stat from the Positive UK project that was done alongside this. They secured over £2 million worth of benefits for the people over a three-year period. And that's people that had been trying to get benefits, couldn't get it, but with the support of a professional advisor, were able to then secure that. And what I would say is that for a large number of those people, and for the people seen in these programs, they weren't necessarily British born, English was not necessarily their first language, and anybody that's had to deal with these systems knows that they are there to put people off and to make it really difficult to get your needs met. So, the results from Metro, so this was the re-engagement in care project. So there was support, targeted support for over 100 people with complex needs. 60% of those were forwarded on and into the voluntary sector for additional support. Out of those people, 85% achieved an undetectable viral load within the course of those here within 2 years. And when you think about the challenges that we see and people, as I say, disengaging and re-engaging, sometimes within a year, the difficulties that were addressed here were multiple. Stigma was clearly one of the primary ones. Again, there were a large number of people that weren't necessarily British born. When they were white gay men, there tended to be issues around drug and alcohol. And so the pathways then into that ongoing support through the voluntary sector were key in relation to the successes that we saw from it. And what we then saw, just as a result of this, so although we were looking specifically at this group, as an additional benefit, the fact of having the peer support worker in the clinic and as part of the MDT resulted in over 200 additional referrals into the voluntary sector for unmet needs and issues that were going to be able to be supported by the voluntary sector. The point that I'd make when it comes back to PROMs and the fact that very few of us living with HIV have ever filled in a PROM is my belief is that part of the rationale and the challenge in implementing PROMs by the clinical teams is a lack of resource to be able to meet and address those unmet needs. And so this approach of having voluntary sector workers paid and integrated within the clinic means that that support is available and you can ask those questions with the knowledge that you can make the difference that's needed. And so last but not least, the Positive UK, in partnership with Plus Health, NAS and Chelsea and Westminster clinics, we supported nearly 300 people, and with 2/3 of those being referred again into voluntary sector support. We implemented an in-house e-referral pathway. So being part of the MDT makes a difference, but not having to go to an external organisation makes a huge difference. So just having peer support at chelwest.nhs increased our referrals 12-fold. And that happened within the first kind of 6 months. When we look at the referrals for peer support, so it frustrates me still because I'm still seeing it in other clinics. What happens is when somebody's diagnosed and they have that first appointment with a doctor or a nurse or a health advisor, and they say, oh, and would you like to speak to a peer support worker? A, does the doctor or nurse know what that means? B, do the people just diagnosed know what that means? And C, when you're in that state of crisis and just having that first appointment, are you in a place where you can even conceive of wanting to talk to somebody else? The answer to all three of those questions is often no. And so what we said was, okay, we've got these ideas as to what we do. Oh, no, let's do what we've done first. So for 3 months, we did it as they wanted us to. And we put a peer support worker referral pathway in. And what we saw was 1 in 10 of those people that were diagnosed took up support. We said, okay, you need to change now. How about we do opt-out? And you give us that 3 months of the list that you have now, and our peer support workers will give them a call and offer them peer support and explain what they do. And what we saw with that call over those 3 months, 1/3 of people said, yes, I would. I'd like to talk to you. That would be great. So we said, okay, that's a great improvement. Now, what we think is, and what we saw from that, the longer you've left it, the less likely people are to take up that support. So let's do this on a weekly basis. You give us that list of your newly diagnosed patients for the week. We'll give them a call. And what do you see? 67% of people say, yes, I'd like the support. And actually, the majority of the 33% that didn't were people we couldn't reach by telephone. And so the idea about having an MDT where you have a peer support worker is great, and it really makes a difference. But if you don't have a peer support worker as part of that newly diagnosed appointment, you're missing a huge opportunity to address stigma, to deal with those unanswered questions, because with the best will in the world, when a patient is talking to a doctor or a nurse, their anxieties, the fact that they can't really adjust to their own diagnosis, it's much easier to ask somebody else that lives with HIV about that. So they were some of the recommendations we have moving forwards into the next round. So basically, we feel that peer support is the missing piece of the jigsaw when you're talking about whole person care. The medical side, and we all know that when you look at health and well-being, medical issues only account for 20%. 80% is wider social determinants of health. And so having delivered these 3 years of programs, what we've now got in place and what I'm managing in the Getting to Zero program is a program to integrate peer support workers in every London clinic. What we then also fund is the voluntary sector backup support on all those issues that have already been identified, so that we have the pathway straight from the clinic into the voluntary sector as a joined up program between the collaborating organisations. And so it becomes a genuinely pan-London approach and looks then to be able to assess and monitor the improvements in well-being, quality of life, and hopefully stigma reductions as well. And there's a quote there from somebody who was through the re-engagement in care program. And that fact, that somebody would be battling mental health on their own for years without knowing how to ask for help, to be offered that by somebody that understands that has walked the walk in your shoes makes such a difference. So I'd like to thank the team that delivered this across the 3 clinics. The clinical leads who supported the work, and if you're interested, you can see the various programs and reports on the Fast Track Cities website, and thank you.
Great, thank you, Gary, and more rich information for us to think about this afternoon. I'd like to say thank you to the 3 speakers for being up here. It's a scary time for people. Now it's even more scary for them because it's question and answers. What I'd like to say is please be kind in your questions. There's probably a lot. I'm going to stand up here so I can see the whole room and point to people, but any questions, please raise your hand. Yes. Here. There should be a roving mic somewhere, hopefully. No, you need that. There we go. I'm like Gary, I can't see without my glasses.
Hi, I'm Jo Copping from Bristol Consulting Public Health. We have a fair bit of peer support in Bristol. What I haven't heard much about is at the conference this time round is around funding. So Fast Track Cities London is a slightly different. You do have a budget, whereas other cities don't have the same sort of budget. Who do you think should be responsible for funding that peer support within clinics, as you talk about?
Who do I think should? The ICBs. It should be part now of the MDT. The rationale for us doing this implementation through getting to zero of peer support in every clinic is we have allocated a specific amount of funding per ICB. And that makes no difference as to how many clinics there are, because we have a lot of clinics in London. And what we're going to do is look at how much was spent by us, how much came in to provide peer support as part of the opt-out testing, how much was also linked in via potential funding through local authorities, and what that delivers. So if we can provide the ICBs with this is the cost per ICB for peer support in all the clinics as part of what you're going to be funding for HIV treatment and care, bearing in mind that a peer support worker is generally around a band 4, so, you know, not the most expensive part of the team by any means, and the fact that, you know, one disengagement from care and admission into hospital saves the NHS £100,000. You put those figures together and say that, you know, so for every person that is retained in care and doesn't drop out, you've funded 3 full-time peer support workers, basically. And so what we want to do is that over the course of this next 18 months, well, about 15 months that we've got left, is to be able to make that case to say, this is the standard of care, this is what BEVA recommends, this is what the CRG have recommended in their service specification, this is what we know it costs, this is what we think you should be providing, and maybe what we've done is not quite enough, or maybe it is, and we can make that call. But this is now what you need to fund as business as usual. So don't give the money to Fast Track Cities. Give it directly to those voluntary sector organizations as part of that MDT that you're going to fund for HIV care and treatment. And so if we can make the case effectively in London, that should be the case that's for anywhere in the UK. Clearly, the devolved nations will have to have their own arguments with their own services. But I would hope, especially as we work across Fast Track Cities and between, that we can make the case together for it.
Can I just clarify? So you're saying the ICBs, because the ICBs are taking delegated treatment, so that delegation hasn't happened everywhere yet?
No, in London, it starts from next April, and so
yes,
we want to be ready for it, to be able to say, you're about to commission, this is what you do. If you're not ready to do that, give us some more money, we'll continue it for a year until you're ready, but we've got the case and we can show you effectiveness already. Yeah, I
would agree with you. Yeah, it'd be good if we could have a whole-scale approach on that one. And
Great, thank you. Other questions from the audience?
Just before that, I'd like to give a shout-out to the Evolving Care report by Fast Track Cities London, which was, it's 2 years old now, but it maps out what the priorities were and gives the answers to the ICB, so follow that up.
Great, thank you, Mel. Other questions, anybody? Yes, and then over there. Okay, the lady in blue first.
Mine is just a comment, really. So I'm doing work on the opt-out testing. We're doing the qualitative evaluation of opt-out testing in EDs. And interestingly, I was speaking to a community organisation who said that they're getting very few referrals from the ED. So they work somewhere. So it's just interesting and something we need to keep an eye on, that people who are being diagnosed in ED aren't getting either referred or not thinking that they need peer support. And I think having someone in clinic would make a big difference for that. And so it's just a comment, really.
So certainly when they did the first round for the very high prevalence areas, one of the things that you look at in relation to the treatment and care cascade is that, you know, the testing or being retested, being referred into care, being engaged in care, being started on treatment, being offered peer support, it really drops out, which is why actually now when we went from very high to high prevalence areas, the wonderful Ian Jackson, give us a wave, basically went from a recommendation for providing that funding to making it a stipulation within the contract that this 10% of this money has to go to post-diagnosis support. And so I think it's about both those things. It's about making sure that the pathway is as short and as easy as possible with as few barriers, and that it works for the newly diagnosed, for those re-engaged, but with the understanding is that if you've got small numbers, then use that money to look at those with complex needs who may be at risk of disengagement, because prevention is always going to be better than cure.
Great. Thank you. This gentleman and then this...
My question goes to, is counseling, is it part of the intervention used? Because presently, I found out that counseling is no more making meaningful, it's not as pronounced as when HIV is at higher level. Are we using the impact of counseling the new diagnosis now? Because counseling is still a main focus to reduce the impact of self-stigma and stigma associated to HIV. Thank you.
So yes. So in relation to the peer support offer, that includes a degree of training around health coaching, so that there's the understanding about how you engage with people around their health and well-being. But separately within both the 20 to 23 program and in the current Getting to Zero, we funded Living Well to deliver counselling, coaching, and support groups as part of that around well-being and mental health, because the recognition is that peer support will do a lot of that, and we see in clinics where people are being referred to peer support and to psychological support. Often, that engagement with the peer support worker, they come in when they say, I don't need psychology, now I feel much better. And so I'm not saying peer support is the cure-all, although it was pretty good for me. But you need to then think about what the needs are, and clearly there are significant mental health issues along with the HIV diagnosis. And so that need for somewhere like Living Well, the focus that they have on counselling, therapy, and coaching is a really key one. So yeah, we fund that as part of this program.
Thank you.
Well, whilst the mic is moving over, just a quick question for Alison. Going through your presentation, a question that often comes up is, do we have an accurate understanding of the number of people actually who have disengaged with care, or have we overcalculated it or undercalculated it? It comes up from time to time, and I'm just wondering if you would be able to comment on that.
It's not an easy thing to do. There's people who are not engaged in care for a multitude of reasons, and that kind of enacts itself in reality in many different ways. People come in and out of periods of their life, whether complex needs, difficulties, etc. So it's a very difficult thing to measure. What we've tried to focus on is people who, we've looked at guidelines and tried to centre on what proportion of people are not seen at least on average once a year, which is the guidelines. We are confident in that because we're able to match accurately, and we do follow up with clinics to see if people have left the country. When it comes to longer term, we are less confident because the reliability of the matching is less good, and it's more likely people may have left the country. We also audit the lists that come back to us, and it does seem to be reliable. So, yeah, we are relatively confident about it, but there are obviously, we can't capture all the nuances. There's many reasons why people are not retained in care, and we need to make sure the systems are flexible enough to be able to measure that.
Great, thank you.
I'm still holding onto the mic,
Okay.
I'm sorry. Because I just wanted to answer about counselling, because, I mean, we got from that presentation that it was stigma still was the big thing, and a lot of people referred to what was IAPS and is now talking therapy within the NHS. We're experiencing stigma, so there's a really good training that I'd like to direct people to that's available for all counsellors. So if you're doing IAPS, look at it. It's called Open Door or Bridge 2, I can't remember, but look at it, and there's training for your talking therapy counsellors to be HIV aware so that we reduce that stigma. Now I will pass.
Thank you. Thank you all for your presentations. A question both for Garry and for Dee. I wondered if there was anything that either you've seen in the clinic work or in the literature review around like training or upskilling when we're bringing the peer support workers in? Like basically, how can we make sure that the people we're bringing in are well prepared to do the job and then are able to make sure that it's a sustainable program, if that makes sense?
Well, it's an interesting question. Thank you, Haley. I can't really say that the literature review covers that much details, and I think one of the vital piece of evidence we found there is actually on Garry's report, probably. I think what we notice is lots of people saying the disengagement is due to sort of a lack of sympathetic approach from the healthcare providers, and then the stigma they feel when they interact with healthcare provider. So I guess that in another way proves to you that there is still a lot of work we need to do to actually sort of reduce stigma among the healthcare teams, and then maybe especially make a wider sort of a spectrum sort of education, because we are seeing that from not just GPs or pharmacies. We also talk about healthcare facility, nurseries, things like that. So this is a really wider sort of a picture of all health providers. That I think that is what has been seen in the literature review.
So in relation to the peer mentor training, so the peer support worker, peer navigator, there's lots of different terms depending on where you are in the city, in the country, and sometimes within a borough as to what they prefer to say. But peer support workers undertake the Project 100 training, so that's what I joined Positive UK to deliver, and it's an accredited national training. Put it this way, what we've delivered in the second round is additional social prescribing training, because we recognize that social prescribing is one of those key elements of the work that is identified and prioritized by the NHS, but that we don't do in HIV, or do we? Yes. Because actually when we passed on the peer mentor training to the social prescribing lead for London and said, look, this is what we do, can you augment this with what you need for social prescribing? And he said, no, because you do more than we do in social prescribing around this communication skills, the engagement, the pieces around health coaching that's in there. So your training is actually better than the current standard of social prescribing training. So one of the things I'd say is that the barriers in the past to this work and to the work in clinics has been a mistrust from healthcare professionals of the professionalism of the patients, because we are still patients, even though we are working and volunteering as peer supporters, we're still patients, whose qualification is having got an infection. And I think that's the challenge. It's about changing that mindset. So when I talk to doctors and I defer to the fact that they have years of training experience, I do also mention the fact that I've lived with HIV for 33 years now, and so I have a pretty good understanding of it, and adherence to medication and engagement in care and what my needs are. And so the recognition that it needs to be both of those things. So the BEVA standards in 2013 said that peer support was essential, but it recommended recruitment, training, supervision, compensation for that work where possible. And so that when Project 100 was launched and we started to do that, by the time it got to the 2018 standards, instead of one quality statement, there were 7 auditable outcomes out of the 8 standards of care for peer support. And I think that shift was because of the fact that we recognized the need and we delivered a way of professionalizing peer support. Because you need to be able to demonstrate that you're trustworthy, that you're going to be delivering quality support. And then, obviously, as part of this program, that you get an honorary contract, that you get the training that's delivered in the trust around confidentiality, GDPR, with any other staff member. And that, again, that you pay it, that you recognize this as an integral part of the team. That starts to change hearts and minds a little bit, despite the fact that we still see gatekeeping. But then, obviously, the other work that Fast Track Cities London are doing are providing that training through the HIV Confident Charter to ensure that the other healthcare providers also have a better understanding. So you have the bottom-up approach, you have the top-down approach, and then you have that work within the MDTs, which hopefully changes things as well. And I think really for HIV, it has always been the case that combination is what works, and that you can't just have one thing to fix it. So you've got to come at it from every angle.
We've got time for one last question, and somebody over there has been waving at me for a while. So as Mel's sprints across the room, doing her Olympic bit. The lady just there.
Thank you very much. My question is, my name is Stephanie. I'm the Health and Wellbeing Officer for Caribbean and African Health Network. So my question is about the peer support. I hear so many questions and responses around it, and I think that's just one approach. And you said most of the peer support are in the clinics. So the question is, I do a lot of community engagements, and sometimes you get some new HIV new cases, and some of them don't have access to sexual health clinic. I've met some people who have been in the country for 5 years and I've never been to sexual health clinic. So how do they get that support? And sometimes they give some wrong information in the process of testing because they are not too sure of where their information will be passed on. So how do you trace those cases? And I've also worked with students who come into the country, and some of them have been HIV positive in different countries before they came, and they don't have that support. So how can they get the support?
Okay, that's a huge question. We probably could be here all afternoon. A brief response?
Yeah, that is a huge question. I think if somebody is diagnosed and they're linked in, not just to the medical support, but to the wider voluntary sector support, that for me is where you get the best bang for your buck in relation to that ongoing engagement. In relation to complex needs, disengagement from care, as a result of that first round of Positive East work, for example, the fact that now they come to Positive East in advance of the MDT around those patients that they're about to be seeing to check whether there's pre-existing knowledge of them, whether they already have relationships, whether that might be a way into those things. And so I think the nature of what the work is that's being done, the collaborative partnership between all of our voluntary sector organizations and then between the voluntary sector and the clinic, having those multiple touch points and engagement points gives you a much, much better chance of success than making it the expectation that at some point they'll go to a sexual health service, because it needs to be different approaches and different entry points. Some people are more likely to go to community, some people will go to the HIV service, but you need to link them together if you're going to really make sure that you catch those people who may fall through the cracks.
May I just add something on top of what Garry is saying? I think when we talk about peer support, it's not just simply someone with a living experience to talk to another person. Peer support itself is actually multidisciplinary, and then you need lots of sort of pathway behind you. So you can talk to people, there'll be housing, finance, there's a lot of different aspects, immigration. So it's not just simply, so, oh, we're going to support peer support. You know, you have to have lots of other things in your plate that you can actually offer to the person you're trying to support.
Yeah. So we need to just pull it together, coming to the end of the session. But I think what we've heard today is what's happening with the data? Do we understand the data, and what do we do with the data? What does the research actually show us? We know the factors, the research is there, but how do we take the research forward, and actually how do we implement it? And as Garry has demonstrated, there are different models in place where we can actually implement it to re-engage people, help prevent disengagement. But what this actually means is probably a challenge to our practice, a challenge to the way we are sometimes working in clinics and in the community. And what I'd like to do is say a big thank you to Alison, a big thank you to Dee, and a big thank you to Garry for their presentations this afternoon. I've learned a lot. I know that they've put a lot of time and effort into this, so a big round of applause for everybody. We finished about 3 or 4 minutes early than we were due to, so it's tea break, and then it's back to the next session. Thank you, everybody.